Good afternoon. It's almost 2:30, we're about maybe 30 seconds shy, but I will call the meeting of the Ottawa County Community Mental Health Board to order. If you will please join me in come to you thankful for this beautiful spring day and all the renewal that it represents. We ask for your blessings as we strive to help those in need of our services and the compassion and understanding of others in order that their lives may be complete and fulfilling. Guide us in all the efforts and keep us mindful of your teachings that we treat others as we wish to be treated. In Christ's name we pray. I call your attention to the mission and vision statement that is included in your agenda. And this will be our first opportunity for public comment. If you have comment you wish to make, please state your name, and the location within Ottawa County that you live, township or city, and your comments will be limited to 3 minutes. We'll start with folks that are attending here in our boardroom. Are there any comments from anyone? Seeing none, do we have any folks online?
No, we do. Yeah, right now I'm the only person online.
Any other public comment? We have a consent agenda to approve of the agenda for this meeting, 2022. The minutes of our April 24th meeting. I have a motion. Or any discussion, any correction? Hearing on all in favor of the motion presented, please say yes.
Yes.
The same. Okay, that motion carries. Thank you. Next we have a presentation from Ann Herbie. Did I say that correctly? Family Services.
I should tell people first that they're working on the roof. So if you're hearing what sounds like they're dropping 90-pound blocks of wood, it's just me.
They are almost done.
Yeah.
It's been a couple of weeks, so yes, we are hoping they're supposed to be on.
So by next board meeting, we'll be finished.
Yeah.
I hope so. I hope so.
Either that or they'll take a break during our board meeting. Okay, I'm sorry, continue.
That's all right. Greetings, everybody. It's my pleasure to be here. My name is Ann Hurdy, and I'm the program supervisor for Family Services. So I supervise all of our services for youth birth up to the age of 21. And so I've got some information to present to you today. So Patricia's pulling it up right now.
Pretty soon we're not gonna be able to.
Right.
That's not it. Oh, you won't let me share. Hold on, sorry.
Split screen, Patricia.
Yeah.
Richard, our IT guy is here.
Oh, that's why. Try this. There we go. Now we'll share their screen. Hooray.
Perfect. Thank you, Patricia.
Sure.
All right, so I've been here for almost 15 years now, serving as the program supervisor, as I mentioned, for Family Services. And over the past 15 years, the next slide will show we've got a fairly robust staff. We have been growing tremendously over the past several years. We certainly have quite a few staff internally. Internally, we provide the most intensive services that we have. So for instance, on the left-hand column, we have home-based therapists. We have some outpatient therapists, supports coordinators. We also have our psychiatric services. We have Dr. Drum 2 days a week. We have a nurse practitioner, Laura, 3 days a week. We also have our peers and then community health workers. And then we just recently added some on-call mobile crisis staff, and I'll talk a little bit about them in the future slides. And then on the right-hand side, these are our contract agencies. So in Family Services, we are very much split between in-house services and contractual services. So contractual services, we have 6 outpatient therapy contract agencies, and they are spread around the county, which we have found helpful to decrease that transportation barrier that many of our families experience. I will also note that for our outpatient therapy, if a youth is getting services, say at Second Story, for instance, in Hudsonville, they are still eligible for other services here. So for instance, we don't expect Second Story to provide the psychiatric services. We provide those services. If the parent needs the parent mentor, community health worker, they're still eligible for those services as well. The hub of their outpatient therapy just happens to be by a contract agency that is close to their family location, and it also accepts their insurance. Other services that we have contracted out are wraparound services, infant mental health, which is birth up to 47 months. As you see, 13 contract agencies. Our largest contractors right now are related to ABA, Applied Behavioral Analysis Therapy. That is for youth that are up to the age of 21 who are diagnosed with autism and meet the criteria for ABA according to MDHHS Medicaid manual. We certainly work with our fiscal management services, or FMS, so families can access services through self-determination. We have respite providers, respite camps, community living services, and then we also have some ancillary therapies like physical therapy, OT, PT, and recreation therapy as well. So it's a fairly robust array of services that we're able to provide. So looking at the numbers, as I mentioned, we have grown tremendously over the past couple of years. As of last week, Wednesday, we had 731 youth. That's again, births to 21 who were open to our services. Half of those youth are somewhere in the process related to the ABA, Applied Behavioral Analysis Therapy. Half of the youth who come into our door are presenting as meeting the diagnostic criteria for autism spectrum disorder. So we're doing our best to connect those youth in a timely manner. Some are already getting services. They're fully in it. Some of them have been in it for a couple of years. Some youth are waiting for the initial testing. Some are waiting for an agency to be able to start providing services. But half of our kids fall into that category. And then the other half of our kids fall into more what I'd call traditional therapy, talk therapy, behavior therapy, play therapy, etc. And that, again, that is either provided through our home-based therapists, which are housed here at CMH, but are out in the community pretty much all day, or one of our contract paid outpatient agencies as well. That number, 731 that are currently open, does not include youth who are served through our traditional crisis services. That is, those are in additional youth as well that we don't have coming in this week. As you see on the right, the number of families coming to CMH to access services for our birth to 21 is growing. Those are monthly averages. So fiscal year 2020, we averaged 23 youth coming in our door from the Access Center. This fiscal year so far, so the past 7 months, we're averaging 34 new youth coming in our door through the Access Center. So obviously that is a fairly significant growth. That number does not include youth who maybe get transferred to us from another county, or it doesn't include, say, a family closed temporarily, came back through 6 months later, and we do what's called a rapid readmit. So again, our numbers certainly would be higher than that, but it is worth noting just what a tremendous growth that we are seeing. Mm-hmm. Yes, thanks.
What's your average on that intake?
Yeah, great question. Our average age, actually, the whole time I've been here is 12. Mm-hmm. Yep.
What's the average wait for those folks that are waiting for testing? And then what services are they provided while they are waiting?
Sure. Absolutely. So for that initial, it's called an ADOS test to determine if they meet the ABA criteria as outlined by MDHHS. Sorry, all those acronyms I use. Please stop me if there's too many. Our average wait right now is about 2 months to get that ADOS testing done. I'm thankful that we're at 2 months right now because we all know that we're all competing for those same psychologists to do the testing. While youth are waiting, it's really up to the family what additional services they are receiving. Everybody is assigned either a supports coordinator or a therapist. There are some families who say, we just want the testing. We don't want any other services. That's absolutely fine. So they're going to have a supports coordinator to walk them alongside all the paperwork that comes with that. ABA services. Other families might be enrolled already in our home-based therapy, might be getting outpatient therapy or something else. So we really do family-driven youth-guided principles here. And so whatever the family chooses is how we help connect them to services. So great question, Dave. Thanks.
Are the wait times longer than what they were pre-COVID?
Actually, they're less. They're less right now. Yes, it is unfortunate to say how long our wait times were at one point. A couple of things I think has changed. Probably the biggest thing I'm very thankful for is that initial ADOS testing that says, yes, you meet the criteria. We previously had to do it every 12 months. Thankfully now MDHHS is back down to once every 3 years. So that has obviously helped quite a bit because now we're not trying to retest kids and get new kids in all at the same time. So that has actually helped. So yes, we're actually less wait time now than we were.
Does that extension in testing time, does that create problems?
I think the frequency of testing was absolutely unnecessary because once a youth is receiving applied behavioral analysis services, they actually meet with a master's level person, well, regularly, but they also have additional testing every 6 months to say how many goals have we met, what other goals do we need to set for the next 6 months. So there was already a whole lot of testing going on. So I think it was absolutely unnecessary to do that much of that testing. Yeah, appreciate the question. All right, so as we talk about number of youth, let's also talk a little bit about,
I don't know why it won't go, but there,
there we go.
I have to pound on it.
There we go. All right, so some of our programs, right? I feel very fortunate in the family services program. We have lots of staff and we have lots of staff who are very passionate about working with youth and families. Some of them have been here for a very long time. Some are actually fairly new to us, but we are very thankful for everybody who has that passion. We're also thankful that we have the ability to provide evidence-based practices, meaning that they have been approved by SAMHSA as having good research behind them that says they are valid to use. So we have trauma-focused cognitive behavioral therapy, parenting through change, EMDR, of course, applied behavioral analysis. There's others too. We're really thankful for that opportunity. We also see another program strength is that our services are geared towards youth and their families. We very much have a model that is family-driven, youth-guided, so parents are included in treatment. If there's a sibling who wants to be included as well, and the parents find that helpful, we absolutely make sure that it's a family-focused approach to providing supports and services. Many of our services are delivered in the community. We literally have some families who have actually never walked in this door because all of their services are provided in the community. And again, that is based upon parent desire, what's best for the family, what's best for the youth, etc. As I mentioned, staff are passionate and many staff report that they enjoy working at CMH. Right now, I'm sure you guys have heard many times in this past year how much we're all competing for that same staffing pool. There are not enough people doing behavioral health services. And the staff here are regularly being recruited. And so I am thankful. Many of them say that yes, while there might be some other perks to working elsewhere with higher wages and stuff, that they believe what we're doing here is really important work. And they absolutely love the team atmosphere that we have here at Family Services. And so we're very thankful that they are passionate and they report enjoying working here. Another strength is we provide notable training opportunities for staff. Some of those are internal trainings that we do. Michigan Department of Health and Human Services also provides some of those evidence-based trainings for free for our staff. So many of our staff have gone through that TFCBT or PTC or EMDR because MDHHS provides training cohorts. So we're very fortunate about that. And we are continuing to develop integrated services. So whether that's addressing physical health with the behavioral health needs, we have some youth who have intellectual and developmental disabilities and they meet serious emotional disturbance and they meet the ASD criteria. So we're absolutely doing our best to address the holistic picture of a child and not just parcel out or segment out. This service is over here, this is over here. We're doing what we can, recognizing that these are whole children and some of them have very complex needs. And so we're trying to do the best for them. So while I'm excited about some of the strengths, we do have challenges. Capacity on the left-hand side is probably our biggest challenge, which we are constantly working on. We have 3 applied behavioral analysis agencies that we are currently meeting with who would like to come on board. So that would put us up to 16 contract agencies. Respite and CLS are a general challenge. Therapy capacity, specifically there, it's our outpatient therapy. Again, given the number of youth coming in our door, we're always having a challenge keeping up with that. I want to give thanks to this group because we just added a wraparound coordinator and another supports coordinator. So thank you all very much for the opportunity to do that because that is absolutely going to decrease that capacity challenge right now. It is not new to talk about the lack of inpatient beds, which is certainly not an Ottawa County issue. That is across the entire state of Michigan. The other capacity challenge we sometimes incur as well is commercial insurance. In Ottawa CMH, we have a lot of children who come to us with commercial insurance and Medicaid as secondary. We have to follow the payer of first and last resort rules. So if children have commercial insurance, we need to make sure we're connecting them to a provider who can bill that commercial insurance first, because we can't use Medicaid to pay for something that commercial has to pay for. So we are very much in the child world, family services world, constantly juggling those insurance issues. The percentage of youth with higher acuities continues to increase. In other words, kids coming in with very severe behavioral challenges, that is continuing to increase as well. And yeah, we're spending a lot of time trying to support families the best that we can. We know it, families are under significant stress right now for lots of different reasons. It's a competitive job market. And then the other challenge is that MDHHS, the Children's Bureau, is fairly new. It's about 1.5 years old, and they are adding on lots of staff. And the goal of the Children's Bureau is that they are desiring to expand how CMHs do family services, that birth to 21. So they're switching. One of the major tools we use to determine eligibility coming in the door is called the CAFIS. We've been using it for decades. We're now switching to the CANS, which is quite an overhaul for an entire system to get rid of tools that we've used for decades and switch to another tool. There is also notable pressure with increased expectations to serve more youth. So even though every CMH I know is experiencing a challenge with the number of youth coming in the front door, MDHHS is absolutely pushing that we're going to open that front door even further in the future and serve more youth. So that is a consistent challenge that we're obviously going to be facing, and not quite sure. Gretchen?
So you increased your numbers to like 34 a year. Is that, and so is it across this?
Yeah, 34 a month are coming in the door.
A month.
Yep, a month are coming in the door. Yep.
Because you are 0 to 20.
Yep. So our aging out process, it actually looks kind of different depending upon the population of youth. So for instance, if they have an intellectual and developmental disability, we're starting to look at, do they go to IDD adult services with Beth and her staff? So some youth will transition that way. Some youth will transition to the MI adult world. Some youth will consider themselves graduating out. So they'll decide that they're done with services. So I can get you exact numbers about how many kids we can discharge on average a month, if that would be helpful for you.
Supply and demand.
Sure. Yeah, absolutely. So lots of our youth coming in right now, our average length of stay for many kids with serious emotional disturbance, which I hate that phrase, but that's what we're supposed to use for MDHHS. They usually hung around 15 months for services. We're definitely not that number anymore. We have quite a few youth now who are hanging out with us for a couple of years, and certainly youth who are somewhere on the autism spectrum who are getting ABA. Some of those youth have been with us 6 months. Some of those youth have been with us 5 or 6 years receiving ABA services. So that is definitely presenting other challenges as we keep getting so many kids in the door. And yet some of our kids are absolutely. Yeah, that number has definitely gone up.
I just have a piggyback question to that. So when the person turns 21, and maybe that's not you're not the right person.
No, you're
But once they turn 21
Mhm.
and move to the next, if they go to IDD or something else, do the parents have to start all over again with that process of being determined, or are they automatically move forward?
Oh, great question. I appreciate that. So we walk families through that entire process. We don't just do, hey, you're close to the kid world, so now you got to start all over by yourself. So we're working with our access center. We're working with MI adult services with Beth's team as well. If a youth comes in, let's say 12, right? Because that's our average age. If they come in at 12 and they are determined to meet having an intellectual developmental disability, that's not going to go away. So they are going to be moved to adult services as the parents want to. We have some families who, when their youth turns 18, 19, 20, depends. Families might say, you know what, we're done with CMH for a while, but we're going to come back in at some point. And again, that diagnosis isn't going to change. When they're ready to come back in, they just call and say, hey, my name's so-and-so, this is my child, can I get back in? Yep, of course you can. Come on back in the door, we're happy to greet you. If it's a youth who perhaps meets the criteria for MI adult services, we actually start that process about 2 years in advance, because we really want to be strategically planning about what that youth needs what's best for that family system and how we walk alongside some youth. There are some youth who are moving to MI Adult Services as soon as they turn 18 due to the severity of their mental illness, or perhaps they're no longer living with family, some of those other types of things. Our goal, though, is not to make this a very difficult process. A lot of times we just do this transition planning with the new staff, with the family. Access Center will often review the records to make sure that they do meet that adult criteria for having a mental illness, because that threshold is different than in the kid world. Again, if somebody chooses not to go to MI Adult, but they still need services, then obviously we're working hard to connect them to other community supports and services as well, so that people don't drop off services, unless, of course, that's what somebody chooses to do. Absolutely. Yes, okay, so some current projects that we're working on. I know Lynn has shared a bit about mobile crisis. So we've had mobile crisis start and stop several times here at CMH. So right now we've got grant and Medicaid funding to serve youth birth to 21, regardless of insurance. We are really hoping to get this launched again in the next couple of weeks. We have switched to an on-call model. In the past, we have had staff who were here, but the call volume did not necessitate having 2 full-time staff sit here and wait for phone calls. The service was not well utilized, and so honestly, staff got bored. And so staff left. And so it's been a hard time to fill. So now we've gone to an on-call system, and we've got some staff who are new to CMH. Well, actually, some of them are returning to CMH to serve in an on-call capacity. And then we have some internal staff as well who will be starting that. So we're going to start with Monday to Friday, 5 p.m. to midnight. Right now, we certainly have our CIT, the social worker working with law enforcement. That's happening during the day. And then we're going to do the Monday through Friday, 5 p.m. to midnight, at least at this point to start. As part of this, we are also participating in a mobile crisis learning collaborative with MDHHS because we got grant funds from them. They're asking us to do this, and they're actually trying to change what the model is going to look like. So that's another one of those stressors or challenges that is out there for us. Right now, we've got some fairly simple rules about what that mobile crisis looks like, but they're talking about making us move to an 8-week follow-up process. So if you get mobile crisis services, you now get in-home services for 8 weeks. I gotta be honest, I'm not quite sure how we're gonna pull all that off. So I'm hoping MDHHS tells us the magic formula for that, but we are participating in a learning collaborative as well. And then, as I mentioned previously, we are hoping to add on 3 additional ABA contract providers as well to meet the needs of the youth that are walking into CMH. Our system of care grant is another big project that we're working on. It's a 4-year grant, and we are using those funds to increase community education. We have probably done community education, I would say off the top of my head, to probably 700 individuals in the last 3 years. We're regularly being asked to do presentations on trauma, how to screen and assess youth for mental health concerns, how to do basic case management, talking about fetal alcohol, just all sorts of stuff. We're also providing parent training as well on trauma. So we're excited about the opportunities there. We're seeking opportunities because this was a grant requirement to increase youth and family voice, whether that's here at CMH, at juvenile court, if somebody's involved in child welfare within the school system. So we've been working with those system partners to increase opportunities for parents and youth to have voice. Sometimes that includes staff attending an IEP, for instance, with a parent. Sometimes it's staff helping a youth figure out how to have a conversation with their juvenile probation officer. There's a variety of ways we're doing that. And then we're also evaluating strengths and opportunities of serving youth through TBD. It's an agency that has helped us do some evaluation work about what are some strengths in this community regarding providing behavioral health services overall, not just CMH, but what is the county doing overall? We've got a partnership with Bethany Christian Services, and then we're working on an anti-stigma campaign. So really encouraging youth to say, if something's concerning you, something's bothering you, please speak up, please ask for help. And then I think, is that it? Oh, nope, sorry. Community partnerships, last one, another grant opportunity. We're providing free mental health screenings and short-term case management for youth in the community and doing some case consulting. So that's what juvenile court, schools are able to access that service as well. Multiple partnerships with the Ottawa Area ISD, including the Ottawa Community Schools Network. The trainings, we recently developed a student success collaborative, the Ottawa Area Seamless Transition, which we're also in partnership with Beth and her staff as well. And then there's those other partnerships listed as well. So We try our best to be as integrated in the community as possible, realizing that our kids are community kids. And lots of our children hopefully aren't going to be dependent upon CMH forever. So we want to make sure that we're connecting with the community to make sure that our youth and families are getting support when they're on with CMH. All right, I babbled a lot. Sorry, I hope that was okay.
The
And there's-
crisis response system that you have there with.
The mobile crisis?
you know, with-
Oh, but with the ISD, oh, great question. That's actually a fairly large collaborative right now, which is actually statewide. So we're one of two CMHs represented on a group with the Michigan Department of Ed, the Secret Service, Michigan State Police, and MDHHS. And it is a goal to figure out how to get schools to be able to assess youth for a violence potential, knowing that there's an increase in school shootings and other concerns like that. Since Oxford, all of the schools now in Michigan have been trained on how to do a risk management assessment. So that was phase one. Phase two now is getting all these agencies together to talk about how to do responses when there is a concern. Knowing that that process is taking a little bit longer, our Ottawa area ISD with their schools within the ISD have decided they want to start moving forward on that. So we're actually in a partnership with them to talk about how to be able to respond to that. When a youth is scoring high on this risk assessment, what does that look like? What are some interventions? What are some protocols? So they're not necessarily CMH youth, but we're offering to be a partnership in that way because certainly lots of agencies are looking to us for that sort of mental health consultation and support.
So this is kind of in the planning stage.
Mhm. So through state of Michigan with MDE and the Secret Service, that group, that's taking about a year-long process. The Ottawa area ISD hopes to have something finalized by the time the school year starts. There have certainly been several youth that they've done those assessments for and they've scored high. And so then they've just called me directly to do a case consult to kind of talk through what makes sense. Is this youth involved with our services? How can we intervene and help? Which several of them actually have been in our services. So then we've provided some extra support or services and tried to intervene.
Those
So.
interactions with the student.
Mhm. Absolutely. Yes, it is definitely a whole child approach where we're talking to the school, law enforcement, parents, youth, etc., with a release of information, of course.
There is a tool, risk assessment that already has been created.
Yeah,
I
absolutely.
do have parents about that particular tool or just kind of outcome to will, potentially would they be able to move to?
Oh, goodness, no, that is definitely not the goal. No, no, the goal is to make sure that kids are safe in school. And ultimately the goal of us, the goal of juvenile court and the goal of child welfare is to actually keep kids in the home because we know that research shows that's where children do best is with supports in the home. So that is always the goal. It does feel like an odd entity. They got involved. Her name is Dr. Melissa Reeves, and she is the one who has taught the Secret Service how to do these types of assessments. So the assessment is based upon what the Secret Service has used in the past. The Secret Service is not here in Michigan. They're not doing any sort of strategic planning that way. It's literally Dr. Melissa Reeves is the person. Yes, absolutely, by Dr. Melissa Reeves, who works for the Secret Service.
So how are they gonna administer that? It's still up for, so are they gonna administer it universally, like throughout the school system?
They are only going to administer it when the school staff think it's necessary. So they're not going to force everybody to sit in a room and to go through this sort of assessment. It literally comes about when the school has concerns about the youth behavior, which certainly is being done with parent permission. So parents are being notified when that is happening.
Yeah, teachers or staff in the schools.
Mhm. Yep.
Too regular.
Yes, absolutely. Yep, correct. Absolutely.
Of that assessment, so we can pick it up or.
I can absolutely get that for you. Yep.
Maybe if you could get that to Lynn.
Sure.
Just hand
Sure.
it out.
Absolutely.
So what is the school program called? Is it,
Oh, there's not an official program. Yeah.
it's not a name, it doesn't have a name.
No, it does not have a name. No.
Or the teacher, that was what initiates the assessment.
So that's really at the school's discretion and through the training that the school, we have not participated in that training process. I've consulted with the state, but we're not involved with the training process at all. So the school staff would actually have to tell you what sorts of red flags. I know for a few kids, you know, for instance, like a youth has said, I want to hurt everybody in the school, right? So that's been the red flag that sort of triggered that thing, so. Mhm. Absolutely. Again, in consultation with parents, so parents are aware and parents are staying in the loop.
I think maybe perhaps before we did it.
Okay,
Seems like a very appropriate critical program.
Mm. Absolutely,
Nationwide.
yes.
On the school tried it already or started it, or do you have any schools that have given you progress or
Mhm.
lessons learned?
Yep, so every school in Michigan has had somebody who has been trained to do the threat assessment, and then they're also doing a train the trainer model. So they're training people in the schools, right, to train their colleagues how to do it. So yes, we have been actually consulted by 3 different schools here within Ottawa County when they had a youth who they had significant concerns about. Mhm. Mhm.
Any other questions for Ann? Great, thank you very much. Go ahead, Rich.
So here 2 days a week.
For kids, he's here 2 days a week. He does adults 2 days a week, and then he has administrative time as well. Yes,
Yeah, of course.
sure. Yeah. He's out sick today, so, yeah. Yes.
Sure, you'd just like to pop in.
It's perfect day.
Yeah, it might be, yes. Yeah, no, we'll schedule a time for him. Mhm.
Anybody else? Any last questions? All right, great. Thank you very much.
Thank you all.
Great job. Next, we have an update on mental health knowledge. CCHC.
So I'm Anna Barrett. I'm a program supervisor for integrated care and community. And this is Chelsea. I'm Chelsea. No, that's okay. Chelsea Eisenler, and she oversees our CCBHC activity. Hi, everyone. You get both of us today. So I'm going to start, and then Chelsea will finish with CCBHC updates. So today I'm going to hand out the draft of the mental health millage programs that I believe Lynn has sent to you guys as well. So it's been updated a little bit since it was sent to you. This is just an overview of all of the programs that we have running through the mental health millage here at CMH. And the addition that has been made, I think, since the last time you saw it is going to be in that last column, where for some of the programs that we're actually funding multiple organizations, we've added in what those providers are and the funding amount breakdown for those. This is a work in progress. So if there are things as you're looking through this that you see that you would like us to include or you think are missing, just let Lynn know, and then her and I can work together to make sure that it's up to date. But this is the most comprehensive listing of those millage programs. The other thing that we've included in it are some of the videos that we've done over the years with millage programs to give you a better sense of what those are. So you can sort of see things in action that are happening there.
And the dollar amounts that are shown for each of the agencies, those would be the current contracted amounts.
Yes. So if, as you guys look through it, like I said, have questions, let Lynn know, and then her and I can follow up unless you have more if you're glancing at it today. I did already notice a typo in my second box down, so I will be fixing that. I missed the message. So if you don't have any questions, we'll have Chelsea go into her CCBHC update.
Yeah. So the village. And then for what medication?
Correct. It's really relaxing to have that stuff dropping on your heads. So this is what Chelsea's passing out.
Yeah.
If you want to pass it around.
So what you'll see is a wrap card explaining a brief overview of what CCBHC is. And for those that don't know what CCBHC is, it stands for Certified Community Behavioral Health Clinic. It's a SAMHSA grant that we were awarded back in 2021. It's a 2-year grant, so we're wrapping up year 2. We did just apply for the future funding announcements that announced for CCBHC. It's called Improvement and Advancement. So we just submitted the application on Friday, which is super exciting. We also applied to be part of the state demonstration for CCBHC. There's not a lot of details. We expect to know more, hopefully within the next month or 2, but that is where we're heading. We're continuing on enhancing and improving our integration of care with the folks that we serve, and looking at our consumers through a whole person lens. And I see some familiar faces, but we did host our second health fair Foundation Earning, and I counted this morning, we had 37 organizations participate. So it was really awesome. And we had really good community participation, community members participation. I think we had about 100, I would say, throughout the 4 hours that we hosted it. And there was a wide variety of organizations. So it was a really cool event to see folks come out to. So that was really exciting. We're also offering some really good initiatives through consumers and even community members. It's really open to all. We have weekly yoga. We're going to be starting cardio drumming. We're going to do a walking group. We do mindfulness. We do a monthly support group. We do like self-care series where we do mindfulness journaling and that sort of thing. So it's been really awesome to have these type of events here at CMH, not only open to just consumers, but to anyone that, you know, could benefit for these initiatives. So, something else that we've started recently is you can see our newsletter, which is a great place for folks to check out what's happening here. There's a QR code with the calendar, with the list of everything that's going on. We have so much that I couldn't fit it just on a newsletter. And it's just a really good place to inform people of what's happening here.
And for that newsletter, if you aren't signed up for Gov Delivery Bulletins, if you sign up for the Gov Delivery Bulletins through miottawa.org for community mental health updates, you'll get this newsletter every month digitally. Otherwise, we do have it available in paper and I believe email.
Yeah, so we email.
We get separate.
Yeah, we email those that have said it's cool if we can communicate with them via electronic. So, yep, emails, print, they go up on the TV out here in the lobby too. So lots of different ways to inform people of what's happening. Yeah, it's for $4 million. And so the difference is, this one, well, it was 2 years for 4 million. This one will actually be for 4 years for $1 million each year. Yep. And this current goal continues to focus on our current goals and just the continuation of what we've been focusing on for the last 2 years, which is exciting.
So integrated healthcare, we're working on the mind and physical health.
Yes. So part of that is the National Outcome Measure Survey, so NOMS. It's a SAMHSA, it's a grant required activity that folks do at baseline. So that initial interview and 6 months later, and then again at discharge when they leave our services. So in full transparency, it's been a little bit difficult getting these participants to complete the NOMS. We're doing some workflows and trying to be creative with how we complete these NOMS. But that is how we would track the the outcome measures, but there's also, we collect a lot of data through our day-to-day operations. And we have a program evaluator that is able to run all of those reports and be able to look at the dashboards and to be able to compare that information and that data.
The other piece that we're doing, Bob, is tracking specific goals that we've written into the grant. So that we do use some economics data, and we're using data that we're collecting in our electronic medical record to see, like, are we impacting obesity rates here at CMH and getting people healthier. So when Chelsea comes back, probably, well, my next time, which is 3 months from now, we should be able to report on the full grant and what the outcomes were on those specific goals.
Here's my ulterior motive for asking the question, because I think that data is important, assuming that it has positive outcomes.
Sure.
Then it demonstrates what can be done at the local level in integrating physical and mental health.
Yeah.
And information that we can send to our state legislators. Should they ever start discussions about privatization from the health system under the guise of improving integrated mental health and physical. But we obviously believe it can be done better at the local level than being done at some location, the east side of the state, controlled there or elsewhere. So,
Yeah, I would love to bring some data.
hopefully we can get folks to fill out the forms that help them understand the importance of it.
Yeah,
for sure.
That angle.
And it's intended to be more of a prevention model, prevention of severity of disease.
Mhm.
So all of the programs would be designed to prevent severity.
To prevent and reduce. Yeah.
And it's mainly for substance use disorder and behavioral health, correct?
It's for people who have a serious mental illness, who are at risk of being seriously mentally ill or have a substance use disorder. And for kids with a serious emotional disturbance. But with that, sorry, Bob, we were about to say something. With that being said, our groups, we've tried to really open up to anybody who wants to come in to participate. So like if we're doing a mindfulness group or journaling group, we aren't asking people when they come in the door who you are, what's your diagnosis, just come in and hang out. Like we're really trying to improve overall health and wellness. We're specifically tracking data on that. Yeah.
See a need for that on the IDDD side of the fence.
Yeah, we would like to expand. The unfortunate side with how CCBHC is written is it's specific to people with substance use disorders and mental illness. There isn't really like a sister program that's running for folks with just an IDD diagnosis. Yeah. Yeah, we've tried doing a little with like the Health Endowment Fund grant that we have that's doing some of the exercise opportunities for people. But it's not doing as much as CCBHC is able to do.
Any other questions, Brianna? Anything else?
The organizations and community partnerships, you have it named for the providers and the funding amount. So do these providers report back to you as far as how those funds were allocated or distributed, or is there any type of reporting that?
We go there too.
Right? We go
Yeah,
to-
yeah, they're reporting back on how they've used the funds, how many people they've served. Yeah, yep.
And do they do that?
It varies based on the program. We have some that are doing it quarterly, some monthly, and some that would be more annual, depending on what the funding is for.
I guess that was my question, so how do you determine what the amount is that each organization does? How is that determined?
So that's really working with the organization to determine what they need to provide the service that they're offering for us.
So a certain proposal is written on the activity or something.
Yeah, and then it's worked through with the contract. Yeah.
We ask organizations annually to let us know what their needs are. And that funding is based on their needs and what they present to us. The social rep programs are Those were RFP'd out, request for proposals way back when we first got the millage. And again, those are, we get monthly reports from them. And we're in close contact with them about their funding needs. We have adjusted some of them based on the reports they're giving and what type of services they're providing.
Any other questions? Great, thank you.
Thank you.
Thank you.
Any old business? We'll move on to new business. First item for action is service. A motion?
So moved.
Discussion. We got 5 agencies gonna be disappointed. Oh. Yeah, you like to go over?
Okay, so we have 5 contracts to present to you today. All of them were included in the source of the LRE. First contract I have for you is the Coffee Home. It's a licensed adult foster care facility for the new contract, providing personal care and community living supports, BCCLS services, located in Grand Rapids with a capacity of 6 adults with IDD and MI, mental illness. With 1 anticipated consumer placement, the estimated annual cost is $50,000, effective May 22nd of this year. Second one is an amendment for Pine Ridge Christian Mental Health Services, who is also a PCCLS provider, and to add 2 residential service locations in the existing contract, which are Pine Ridge Interactions Residential Treatment and Pine Ridge Sequoia. This amendment is due to transitioning of a consumer from one of the Pine Ridge homes to these new locations effective May 17. The projected annual cost due to this amendment will be approximately $86,000 more. The third contract is an amendment for Heritage Homes. This is a PCCLF provider as well, and is to include the rate increase for Smith Home effective February 1st. Due to the change in level of care and behavioral plans for the 2 consumers currently placed there. The additional annual cost will be approximately $267,000. The fourth, next is for 70x7 Life Recovery, which is a new substance use disorder provider that will be providing SUD residential treatment and recovery services at 825 Fulton Street in Grand Haven, effective May 15 of this year. The projected annual expense will be approximately up to $50,000, but more specifically will be around $10,000 with current referrals at this location. Last one, the final contract I have is for La Benediction, another PCCLS provider, which is for an amendment to add a transitional rate to the existing contract for a new consumer placement effective May 22nd. The annual cost will be approximately $105,000 more due to this amendment.
So there's a slight change, sorry, in the way we're reporting that financial category. When it's a single contract, we'll report the estimated annual cost for that. So that first home, that's what that looks like. For Pine Rest Christian Mental Health Services, we're reporting the estimated annual increase or difference. And the reason why, so the 750,000 up on top, it's that or more. The reason we're not reporting the exact amount is because we often contract for more than one service. So if we reported Pine Rest's total budget, it would include all of the inpatient stays that we use for them. So it would be the number wouldn't be very accurate if you were trying to figure out how much this particular increase in two of their homes would be. Does that make sense? So for instance,
So
Pine,
all the services are all
yes,
covered under one of the contract.
yes.
As Lynn and I have discussed, what I'm trying to get us to is when we see the contracts in the past, we've always had these ranges, 50 to 250,000, et cetera, et cetera. In some cases where you have homes and bed, somebody may need a bed and a person is added to the home, there needs to be some flexibility. Otherwise, there could be a delay in placing that person because they have to come back to the board and get it approved. So they've always had that arranged, but I've always 50 to 250, just using that as an example is a pretty broad range. So I'm trying to get it when we have contracts where it's a set amount and you don't have that fluctuation, we see the contract come for that year, and that's what it is. And then on the other ones where there's that flexibility, there may be still some range there, or I'm not sure about the Pine Rest contract where you have all of these different services that are relevant. When you have just a special housing service that we might be able to, if it's an agency that we have a track record and history with, and how many beds they might add or need or drop off, maybe we do a contract that's in my world, we call it a not to exceed. So you have a base contract amount, you know what that is going in because we're housing 3 people there. If we had 2 people during the course of the year, there's still latitude in the contract to do that. So the people can be placed immediately without any delay, having to come back to the board because now they're going to go over their contract. So we're just trying to tighten up the numbers so you get a more accurate feel for what those numbers are, contract by contract basis.
The range, should be about the range, you put it at the high end.
If a home, for instance, had 6 beds and we had 6 beds filled, we would budget the full amount. It might be that someone moves out. And so there'd only be 5 beds being used, but it's, yeah, we would budget for all people being in that home for the whole year for 6 beds.
And then surplus, would that go back to?
Yeah, well, first of all, it would go back to us. So any unspent funds we would use within our own operating budget. But yeah, if there were funds in excess at the end of the year, then that goes back to the Lakeshore Regional entity.
Any other questions? If not, then all in favor of the contract as presented, please say yes. Opposed, the same. Thank you, Gina. So our financial report is key.
So I'm Amy Baba. I'm answering a couple of you I haven't met yet. Financial manager, and Nick Saul is our assistant financial manager. I'm going to talk to you today about the statement of activities through end of April of this year. Attachment B in the document. So upper left corner, our mental health fund continues on a steady pace. If you recall, month to month, we've been kind of catching up with our revenues. And those we're within a $2.4 million range now, in a comfortable position. Healthy activity going, revenues and expenses pretty evenly coming in and flowing out. Good activity. Same for the SUD fund. SUD continues in a good position as well. We're, getting closer to our target percentage for this time of the year. We just heard from Anna and Chelsea on the millage and grants fund. Good activity there as well. We're in a good position. One thing of note this month, which hasn't happened up to this point, if you'll notice in the bottom right corner, bottom right corner, the Medicaid funding budget to actual, we actually are in a slight deficit of budget to actual just for April. That really happened because April 30th was a Sunday, and so the expense payment, the revenues were not paid and received until May 1st. So actually May will likely have 2 payments and kind of be ahead of that budget to actual for next month. But that was the first time that's happened this fiscal year. So any questions or?
All in favor, say yes.
Yes.
Cover the next one.
Mhm.
Yep, hello, everyone. Back for another millage adjustment for this month. This is in relation to the Consumer Residential Assistance Fund that Lynn has brought up in previous board meetings. Just a quick synopsis of what this is for. So this will be $100,000. That will be an assistant award based on a first come, first served basis, as long as funds are available. Individuals can apply for once in a fiscal year, which is October 1st through September 30, for up to a $3,000 reimbursement. These can be for security deposit, payment of back rent, accessibility modifications, utility costs, payment of back utility bills to avoid shutoffs, or down payment assistance towards the purchase of a home. And this will be being paid for out of the millage fund balance on an annual basis.
How would the consumer know that this money is available?
We will, we're working on an application, finalizing that, and we will post that on our webpage, put it out in a newsletter, and we'll let all of our staff know that it's available and give them information about how to apply.
You said funds are available for an individual to make a down payment for a home.
Mhm.
These are individuals that are consumers in money.
Yep.
Correct. They have to be a CMH consumer.
But include an IDD, high function.
Oh, sure. I'm sorry, what was your question? I couldn't hear you. Does that qualify for?
I was just curious, is, in terms of the people that would qualify for that, since we're providing a down payment for a home, that's it's MI. Basically our consumers, from MI substance abuse to IDDD, those who are high functioning enough that could live with a certain degree of independence, etc.
Yeah, just to see where this goes. By all means, if it's something that's really necessary, we can look at adjusting that based on it's the millage savings. So on the other hand, if it's something that isn't needed, we could look at that as well, and maybe not allocate that much money. Yeah, definitely. It's kind of based on a program that ran through the state years ago. And I think it was not, people took advantage of it. There wasn't as much money available. So I think it's see how this goes, and I'll report back to you if we've got applicants and where we're at with the budget on that.
Any other questions? I strayed from Robert's Rules of Order on the last two items. Is there a motion to approve?
I'll move.
Before.
Yeah.
Does anybody have any questions about, this is the LRE's financial status through March? Couple months back.
I do, Amy, on the back. Why is Ottawa blacked out?
Those are TCBHC activities only, as far as being a demonstration, providing services and being reimbursed through the demonstration.
Those are the two things that have the demonstration.
Mhm. So going forward, we know.
Oh, I just going, why are we getting this? We're black.
Yeah. Then,
Portrait borders, it's like, even like the board.
We often have someone listening in from the LRE. I don't think we do today, but, we can,
Some of us that are.
yeah, yeah, I can have them. Absolutely. I can have them.
Can add, can add them to our list. Well, we're gonna start bringing agencies in to do presentations, particularly for new board members. So I think next month we have Momentum Center coming in, but we can get already in that mix, so they can come in, it's gonna give us where they're at. Thank you. Executive Director's report.
First of all, welcome Kyle. He was online for our last board meeting, but he wasn't in person, and I just wanted to make sure we all recognize. I truly appreciate his interest in serving on our board, so. I'll give you some updates from the state. Those who have been around for a while recognize the name Jeff Weifritz. He is the current director of the Bureau of Specialty Behavioral Health Services, Behavior and Physical Health and Aging Services Administration. So I don't expect anybody to say that after I just said it, but he's actually leaving. I don't know how long Jeff's been there, probably at least 15, 20 years. He's going to the state hospital system, and we have not heard yet about a replacement. It's always hard to lose somebody with all of that background information. So I think we're a little bit anxious about who's gonna take his place, and I'll let you know who that is when I find out. Continue to be involved in advocacy for the direct care worker wage increases. I don't have any news about where that's at. There were two proposals for different amounts in the legislation, and to this date, I have no. But anything in the right direction as far as getting more for those direct care workers will help to stabilize the system. We're paying attention to what's known as the Public Health Emergency Medicaid Unwind. That's the process whereby DHHS will start reassessing people's eligibility based on their income to receive Medicaid. We anticipate that we will see a pretty significant drop in enrollment. It's still out there as far as what that will mean to us and how many that actually is. We are trying to let people know to the best of our ability that they need to reapply if they're eligible. If they don't know they need to reapply, they will tell them whether they're eligible. We have information going out to the people we serve. There's even placards in the back of our bathroom stalls. Someone told me that's where lots of people get their information, so we're trying to get the word out. From the Lakeshore Regional Entity, I've been keeping you informed about the historic deficit. That was dollars that several of the CMHs in our region expended to cover their overage in Medicaid, with the anticipation that they would be paid back. And that didn't happen the way everyone had hoped, to the point where it had to go to litigation. I let you know that the judge that was looking at that case actually ruled in favor of the Lakeshore Regional entity that allows them to use savings to address that past liability for the 3 CMHs who it impacted. Right now, we're working on how those funds would be distributed. And those are ongoing meetings. So when I know that definitively, I will certainly let you know. Ottawa County was not one of those CMHs that we are due funding. So we balanced our budget those years. Internally, so, you know, I've been trying to keep you up to date on our success or lack of in filling positions. Last week, when I checked with my staff, we have 8 vacancies. Some of those positions have been open for months without, some of them with no applicants at all, which is really concerning. We continue to work with Human Resources, and they've been doing a good job of helping us brainstorm and try some things that we have not tried in the past. But it's really, it's not just us that are having difficulty. Most CMHs, if you ask them, I'm sure would tell you they are not fully staffed. But as Anne mentioned earlier in her presentation, Family Services alone has seen an 11% growth in referrals since the beginning of our fiscal year. So we're as busy as we've ever been. And staff, you know, what that means when there's a vacancy is the existing staff just have to absorb those caseloads, which is difficult to do. We have had some new positions approved, which is a great thing. What that's ended up doing is creating a problem with space. We literally have turned every storage room, every waiting room into cubicle space, and we're still running out of space. So I've met with facilities maintenance and started some discussions about possibilities where there is some undeveloped space in some of our county buildings. DHS is one of those. So right now I'm talking to my staff about what we really need to look at and what projections are. One of the things that's happened recently, one of our contract agencies that we partner with, Goodwill Industries, has told us that they are ending their program. So the program was called Work Readiness Program, and it helped individuals with intellectual and developmental disabilities learn skills, skill building towards employment. Goodwill Industries was one of the last remaining organizations that had a certificate from the department that allowed them to pay sub-minimum wage, so piece rate. And they have decided not to renew that certificate in September. So that's going to impact 19 people. We are working, our sports coordinators are working with those individuals and families to figure out what they'd like to do instead, so we can offer some alternatives. There are other programs out there, social rec programs, other skill building programs, and traditional work. So I think we'll be fine by September in helping people to find alternatives. It's not really surprising. There are some big organizations in the state that have those certificates, but a lot of places have decided not to go that route anymore.
Did they do work readiness and find them a job as well? Or just different sets of life skills. I'm not familiar with them, so sorry.
No, that's okay. Yeah, it was skill building, doing piece rate work, that could eventually lead to a job.
Well, or do they like bring them to different?
It was a separate program. It wasn't one of their, retail sites. But they did do some, work shadowing and work exploration at their retail sites. And that's one of the options that, they said that they will try to find some work for people within the remaining, programs that they have. Yeah, it is. It is when any of our programs end, but, I think it will be okay. I think we'll find alternatives for folks.
Just if I may, just some background on information on that. It's the Department of Labor that issues the 14C program. And there have been advocates who have been advocating for decades to eliminate the program. These are what I refer to often as the one size fits all advocates. Everybody, regardless of their cognitive ability, is able to go out and hold a real job. Now, our daughter who worked at Goodwill, and she'll continue there till the end of May, and then she'll go back and spend her entire week in the drop-in program at Deacon's Conference. You know, she can't. No employer is going to employ her and pay her minimum wage and have a worker being paid minimum wage working next to her, and she's producing a third or half of the product that other person, non-disabled person is. So at least to have a place where people can work and have a sense of fulfillment in doing a job, which our daughter loved, but getting paid based on what she's actually capable of producing on a piece-by-piece basis. So it's unfortunate that they decided not to do that. I don't know that the Department of Labor, I haven't found anything on their website that says they're absolutely killing the program.
Neither.
But I think Goodwill's had other issues with, they've had trouble getting the work ever since COVID, especially. Because our daughter worked there 2 days a week prior to COVID. It's got back to 1 day a week. And her paychecks were $1.20, which is saying there's not a whole lot of, so they're working on other life skills while she's there, so that's good. But and they had the goal of eventually trying to work into where you might have, sorry, it was escaping me, where you might have a enclave working at a local manufacturing plant. So somebody like our daughter could work there, but has all of the supervision necessary to do it, but they're still getting paid by the weeks. But I don't think they've been able to pull that off. I think that might have weighed into some of their decision as well. So anyways, just a little more background information on that whole process. Well, the stated reason is that they see the 14C program going away, that the Department of Labor will eventually phase out and not issue those certificates any longer. And that may very well still happen, Lucy. I don't, again, I going through because we had a letter, you know, at home from Goodwill stating this was going to happen. It would be done by the end of June. And we opted to say, well, she'll finish up May and then we'll switch her back.
The difficult thing, I'm a parent, right? So when your options are very, very few, it's just very frustrating and sad and hurts when the few options you have are being taken away and they're not replaced with anything else.
And with the labor shortage, I mean, this is just a terrific opportunity. I remember, I think it was a chamber meeting that I attended where they were talking about alternatives, you know, for employees.
And we have folks, you know, we have IDDD folks in the community, Floyd Budmeyer. If none of you are familiar with Peckham in Lansing, you can go on their website. Stuff they do is phenomenal. And I haven't heard back from Joe on that. I sent a CEO, I'll send an email to their CEO asking them if they're still doing 14C programs, but I haven't heard back. So, but they do a lot of employment in-house employment, as well as contracts with the state to clean buildings and so forth and so on. So there's kind of a full scale of employment opportunity and work opportunity for individuals, both MI, substance abuse, IDDD, depending on their abilities. And they're a big operation.
Yeah.
And Peckham they have an ongoing relationship.
Yeah, in fact, we just had a meeting, my staff had a meeting with facilities maintenance, and we're trying to get a cleaning crew project started back up, and hopefully some participation. The new juvenile justice building will have kind of like a cafe, and hoping that some of our staff could be employed there. So we've been doing a lot of work on supported employment. Maybe at one of our next meetings, Beth can give you an update on where we're at with supported employment, trying to get people out there working in the community, trying to make incentivize providers to expand. So we can have her give an update on that.
So as parents, we can tell you the challenge. They never. Okay, I'm sorry.
No, you're fine. I did want to just give you an update. At last month's meeting, a couple of people had wondered about some changes at the Ottawa Area Intermediate School District and OAC, and them changing their summertime schedule. We meet with them frequently, but we reached out and asked if they were aware of any parents that were in a crisis situation or didn't have services because of these changes. And they let us know that they weren't aware of anyone, that they weren't working with to find alternatives or to answer questions. The changes don't take place until July. So, we may get more calls closer to then. We have had a slight uptick in referrals, requests for services for IDD. So that might be part of it. And if they call us, we'll certainly work with them to see what types of programming or services they're eligible for. But again, we're in pretty close contact with the ISD. We meet regularly with them. They certainly know how to get a hold of us if they feel like there's people who they're working with who need something. So we'll stay on top of that though.
Or if it's 2 weeks, so things in August, I think.
Yep. Beth, did you hear of any numbers of how many folks were going to be impacted at the school with that change? Okay. And I can find out numbers for you.
My understanding is they don't have enough people to provide the services, and so it kind of pushes that out into.
Yeah. Yep. Yeah, and we're certainly willing to talk to them and talk to the individuals themselves. So, part of our wanting to meet with them regularly and routinely, the schools, is so that no one's dropping the ball. No one's saying, no, you should call CMH and then not telling us that they're telling people to call CMH. So we're really trying to transition, even if it is for a summer, just so we're trying to avoid people falling through those cracks. There might be somebody who does, but again, there's the schools know how to contact us. We know how to contact them. So I guess at the moment, what I can say is the schools did not tell us that there's a pressing need right this second for us to do anything different. And if they tell us that, we'll work with them.
That's just the area center and all the young adult service classrooms as well, that they would be supposed. So once school starts in the fall, would that also be once a week?
I think
for all of the.
for sure, but I think so. In July, it would be the out there. We're gonna start.
If you hear something, you can tell them to call me if you are hearing individually.
I definitely just don't even fathom how people think that parents can find someone to watch their adult child for a be and keep their job. I just don't know what employer's gonna put up with it. It's just insane, frankly, honestly.
Even planning in advance, what those numbers might be, I mean, is there permanent day programs, for instance, for summer or throughout the year? I mean,
Could be.
Strategizing in and around what are those numbers to be potentially impacted? and
Yeah.
how does the community support that?
We'll keep in contact with them. I mean, I kind of feel like we reached out and said, hey, is there anything going on? Can we help you? And they said, we're all set. So, I don't know. And I hope not. We'll stay in touch with them and reiterate that we would rather be prepared than dealing with something 2 days before it happens. Just some quick updates. I talked to you about the medication take back event that happened last month. I do have numbers. We collected 331 pounds of medications and 315 pounds of sharps. We will be announcing in our newsletter that there's a drop box in our location in the lobby. That's fairly new. We had a SUD, substance use disorder educational event on May 10th that was really well attended, about 100 people. It was called Straight Talk, and it's a story from a mom and a son who kind of went through the journey of his substance use, and it's a good ending. So I did not attend, but I heard it was well attended and very worthwhile. We're thinking about inviting them back in the future. Chelsea let you know about our health fair. That was a success, about 100 participants. And I'll leave you with sad news, even though that's probably not the right thing to do, but Rich Francisco, our deputy director, has accepted a job at Health West as their new CEO. Health West is Muskegon CMH. So it's not sad for him, it's just sad for the rest of us. Yeah, but the good news is he'll still be in the region, and we work very closely with Muskegon, so he's going to be a huge asset to them. So
Yeah, and talked about other agencies hiring our people.
exactly, right?
Choose the nicer word than hiring. Best of luck, Rich. We appreciate it. Okay, thank you, Linda. General information, comments, meetings attended. Just as a reminder for board members, Lakeside Clubhouse has their open house this Wednesday from 4 to 6 p.m. For anybody that might be interested in stopping in. They're located at 490 Century Lane on the south side of town. So if you're coming from points east of 31 on the north side, your best bet's probably just grab 31, take that to 16th Street, hang right. First street on your left is Century Lane. Turn left and they're about hitting down the block on the right side or west side of the road. They've got a big sign out front, so it should be easy to find. Any other comments or anything else people need to bring to the board? Gretchen?
This, following up with, some of the constituents, forum. So another thing we talked about was for the organizational chart, having a meeting in the different positions. That would be
We, some of our staff have got that done, so I'll see where we're at, and if it's complete, then we can get that posted.
Anything else anybody has? If not, we have our final opportunity for public comment. If you could state your name and where in the county you're from, and your comments will be limited to 3 minutes.
The self-paid employees just desired the applicants, no applicants too. So in New Jersey, there's this whole self-paid app, and Beth was on that webinar, and it's a map with docs of the employers, so you can see the location of where the docs. And then if you're interested in the job, then contact the app. There's something CMH can do, and we post on the county Indeed website for employee job openings. Quebec County has a Facebook page, CMH.
they have self-healing awareness, jobs, vehicles. Here, and how do I sign up for the CMA check of delivery to the student center and. And, we need a can-do bag. Yes.
Well, I hear you. If it comes back, we need one that's gonna be better managed.
Well, seriously, what? Don't create them. That's pretty much volunteer and nonprofit. Opportunity for volunteers.
You can just take a little time. We'll just have the discussion here in a minute, okay? When Can Do closed, there was discussion with Peckham. If they could start as Peckham, Peckham. Joe Sinha is the CEO. Joe at one time worked briefly for Can Do. I think she saw the handwriting on the wall even back then, and she left and went to Peckham. She's worked her way up the ladder in the last 20 years there. But there was discussions about them starting a satellite, but unfortunately they had just started and invested in call centers, one in Grand Rapids, another one out of state. So they didn't feel that at that time that they had the wherewithal to take something like that on. So that was reasons given, which was too bad, because I would have loved to have seen them come on this side of the state and just start a small satellite operation. Would have been great, but it didn't happen. So might yeah. Yeah, okay. You're all set on your comments, Rosalie? Okay. Till next month, we'll see you. Any other comments? Anybody online, Patricia?
Hi. Hi, I'm Julie with Harrisburg.
If you will.
I have several comments here. The Michigan Department of Health and Human Services provides common community-based services to individuals without Medicaid program. These services help Michigan citizens with disabilities or other health issues with a point or in the community. Our community mental health is in charge of 4 waivers: children's waiver, rehabilitation supports waiver, the 1915I behavioral health demonstration waiver, and children with serious emotional disturbances. We never hear anything about how many people are enrolled in each of these public community-based programs that came as a result of 2 women with intellectual development who went to Supreme Court and said, "We don't want to live in the psych facilities. We want to live inclusive. We want to live in the community." These women went to Supreme Court and they won. As a result, it was the Olmstead Act. As a result of that, it's public community-based services. As a result of that, it's self-directed services, community living supports. We get millions, our community millions of dollars to keep our children out of restricted settings. Yet, as a result, my son is on the rehabilitation supports waiver. There's 101 CMH individuals on the HAB waiver. My son is one of 15 that's left living in the communities. The rest of them are in restricted settings. There's no self-direction available to them, which is contrary to community-based services. So I'm going to lay this to the board and ask that they really dive deep into public community-based final rule. Mandated compliance was March of 2023. Lynn, executive director, happens to be on the state public community-based work group, yet we never hear anything about these wonderful programs that are supposed to keep people in these restricted settings. Now, another concern I have is on our website for CARP accreditation. It states that CMH is accredited in community integration. However, the CARP report says we are not accredited in community integration. We're accredited in crisis intervention. So unless this community mental health wants to be all about crisis intervention and not about inclusion or home and community services, I think we really need to look as to what the park report says we're accredited in, because it costs $15,000 for us to be accredited. On the website, we're saying, the image is saying that they're accredited in community integration, but they are not. So, I think it says, the park report says it's not. Now, concerned about the specialized residential financial assistance program, I voided this. It states here, the state replied, Medicaid pays for the adult foster care homes or AFC license, $250 a month.
Hey, Jewel, thank you.
Sure. And, I'll leave this here. DFCs can only accept the amount authorized for the board. They're not supposed to accept any additional money, so I don't really understand what the specialized residential program is supplementing.
Anybody else in the audience? Anyone online? Tricia, yes.
Questions of this mental health, behavioral health. If I'm just thinking, my son, when he moved out of our house, was about 180 pounds. 5 years later, he's well over 300. He gets nothing from a support coordinator. He was trying to do a Walmart order. And I asked to see it. Boy, we had quite a discussion about what was healthy, what's not healthy, why you're spending twice as much on this. Because he has no assistance in nutrition, and he was eating like a teenager. He's 27 and well over 300 pounds. I think he's gained 20 pounds this past month. And my daughter, who's 25, she went to her first group home within 6 months. And she has consistently gained weight. What's healthier for my kids? I don't know. It's like our son. He's living in our house now. He gets no CLI. He gets, the only ones who get to try healthy nutrition. So I don't know. My house is full. But I would like to know something. What can we do to help my kids lose some weight? I try to take my son and take him for walks, but I don't want to spend money. But yeah, that's my question is what can we do to help them? I mean, because the groceries he was ordering, I love it that you can go to pick up groceries. But we need to take it a step further and how does he learn these things?
It's just a question, if I may. Are you legal guardian for your children? For your son?
So we are not.
Okay, for your daughter you are.
Yes. And she lives in an adult foster care specialized group home.
Any other comments? We're done, Jewel. We're done, Jewel. We're done, Jewel. You're done. Any other comments from anyone else that is not comment? Patricia, anybody online?
I don't think so. I'm gonna look one more time just to make sure. Nope.
All right, thank you. Yes, good.
Yep. It'll be posted with the minutes.
One last opportunity. Anyone else? Thank you. Any final comments from board? If not, I'll take the motion to adjourn.
Move. Support.
All in favor, say yes.
Yes.
All opposed? Great, thank you.
Okay, board members, I got stuff for you. Let's see. That's for you. You went your
And Jerry, once again, Jerry, it blew him away. Since you've been made things are just. Well.
That's been.
Things they say are living in restricted
Is that what it is?
Well.